So we're going to continue on with our assessment chapter, beginning with the secondary assessment. So this assessment can be performed on scene. Usually you're going to do it in the back of the ambulance en route to the hospital, meaning on your way to the hospital. And if you're too close to the hospital, you might not get a chance to do this at all, but I'm going to tell you to try your hardest to get this in so you don't miss anything. The basic purpose is to be systematic. Okay, so you're going to do it the same way every single time. Okay, you're going to check usually head to toe, top to bottom, front to back. You're going to check everything on the patient. That's going to be the normal way you're going to do this. Now, if the patient is actually stable, conscious, they are alert to person, place, time, and event, you're going to be able to actually do a focus assessment, which is an assessment on the specific complaints of the patient. Say if they have abdominal pain, you can focus on the abdomen, that sort of thing. Now, you need to know these terms here: inspection, palpation, auscultation. So inspection is just what you can see with your eyes, what anyone can see. These are all going to be signs. Okay, so you can see it and they're going to be objective. You're going to palpate, so you're going to be able to actually touch or feel the patient, say if they have acute complaint of abdominal pain. So you're going to palpate their abdomen and see if they have any like muscle spasms, anything like that, or tenderness that they can tell you about, which would be subjective here, but most of the stuff we're looking for is objective. And then you're going to auscultate, which is using the stethoscope. And we're going to use the mnemonic DCAP-BTLS. It stands for deformities, contusions, abrasion, penetration, punctures, burns, trauma, lacerations, and swelling. So deformity is going to be anything that you can actually see, like a broken bone under the skin, something where the anatomical structure doesn't look normal. Contusions or bruises. You should probably know what abrasions are. You're going to look for penetrations or punctures, not just from things like knife wounds, gunshot wounds, but people falling on things, that sort of stuff. Any burns where they are, how thick they are, miscellaneous trauma that you might spot, lacerations, which are cuts, and then swelling, which is also called edema to the body. Now, what you're going to want to do most of the time here is compare one side of the body to the other. You can think of things like hip fractures. And what's going to happen is one of the patient's legs is going to be shorter than the other, but you're only going to know that it's actually shorter if you compare it to the good leg. Now, your basic goal is to find whatever you may have missed or didn't see because you were focusing on things like ABCs in your primary assessment or things you might have missed in the quick rapid assessment, that 60 to 90-second assessment during your primary. So, like I said, this focus assessment is for patients who don't have a high velocity like MOI, or people who are responsive and they're not altered. They don't have a decreased level of consciousness for your medical patients. And it's going to be based off your chief complaint. Like I said earlier, things like uh, my abdomen hurts, that sort of stuff. You're going to focus there. All right. And you're going to focus your attention on the body part of system affected by the patient priority. So I'm going to say focus on the system because things like the cardiovascular system are going to be more wide ranging than, say, just normal chest on your respiratory here. So first things first, always expose the patient's chest. You got to take a look or else you're not going to notice things like retractions. If you remember from that video where I showed you the patient retractions, the actual medical professional lifted the patient's shirt so you can see. So you're going to look for things like signs of airway obstruction. All right, that includes things like cyanosis or the universal choking sign. You're going to make sure there's equal chest rise and fall and it's symmetrical on both sides. There's not just one side rising and falling. You'll auscultate for the breath sounds. Okay. You'll measure their respiratory rate here. And you're going to look for retractions and increased work of breathing. The things that can be increased work of breathing will be things like the tripod position. And you already know that adults breathe from 12 to 20 times a minute normally. Now, children normally will breathe faster. As they get older, it'll slow down. And like we said in lab, the correct way to do this, according to the book, is going to be count over 30 seconds and multiply by 2. You want to make sure that the respiratory rhythm is going to be regular for normal patients. So basically from one chest rise to the fall, it's going to be in time. So it might take, 5 seconds from one to the other. And you just want to make sure the interval is regular there. Now, if it's irregular, you don't want them to go from 12 to 20 to 6 breaths a minute or 12 to 20 to 28 and back and forth. That would be irregular. So normally breathing sounds are silent. You can't hear them just with the normal human ear. Now you can hear them with the stethoscope. We'll play some of those for you here in a sec. So any breathing actually accompanied by sounds that shouldn't be there, things that we would call adventitious breath sounds, indicate a respiratory problem, whether it's going to be upper airway or lower airway. So you want to make sure that the patient has the proper depth of breathing. So the chest rather than fall is going to be normal. That way they get the adequate amount of tidal volume. So that air exchange at the alveolar level. And then they're going to have an adequate rate so they can actually unload and offload oxygen, carbon dioxide, as they need to, like normally. Now the breath sounds are typically going to be heard best from the patient's back. I'm going to tell you, and I'll show you in the video here in a second, that you got to avoid the scapula because it's going to dull the sound. So you want to avoid the ribs and the scapula, any bones in the way. As you can see here on the right picture, this paramedic is auscultating around the patient's scapula. And then we'll show you these front sides in the lab here in a second. On Wednesday, actually. So here's some videos to show you what you're actually going to be listening for. So this is going to be your normal breath sounds. And this video is going to be listed as vesicular. It just means kind of normal from the front. This sounds like air moving through a tube. Most common because it's normal. So it's softer during expiration because it takes longer to actually take in air than let it go. As it says here, the inspiratory to expiratory ratio is usually 3 to 1. So 3 seconds for inspiratory, 1 second for expiratory. That's sort of normal. So here is where to put your stethoscope here on the back. As you can see, they avoid the scapula. They avoid the ribs. And what you're going to do is you're going to listen at all the places that have a lung field. So as we said before, the right lung has 2, the left lung has 3. So you want to listen to all the lung fields that you actually can. So you see how the expiration is quieter here. So that's going to be your normal breath sounds that you're going to hear. Now, something else that you may hear that you don't want to hear is going to be snoring sounds. Most commonly, I find that people that have like low blood sugar that are diabetics are going to have snoring sounds, and it sounds just like snoring that you would normally hear. Now, the other sound here is going to be wheezing. Wheezing is going to be a high-pitched expiratory breath sound. It is a lower lung field breath sound, and we'll listen to it here. Like in asthma, COPD. Yeah, because the tube narrows, whistles. So that's going to be an important point here. So, because it's harder for them to actually breathe out air when they're having an asthma attack or COPD, the expiratory phase is actually longer here for them. So they don't have the normal 3 to 1 inspiratory-expiratory ratio. And it is usually expiratory. Now, typically it can be heard basically at the mid section here. So if you listen kind of where they're pointing here, it's going to be at the bronchial level, which is like bigger than bronchioles and alveoli. So it's going to be in the middle sections here that you're mostly going to hear it, sort of at like armpit level, as you can see here. See how much longer expiration is? And next is crackles. So crackles you're going to hear at what we call the backles. Basically, at the back is the best way to hear crackles. It sounds almost like to me if you were to take your hair and rub it in between your thumb and first index finger there, and the sound you would hear, it's basically going to be fluid in the alveoli level, so it's going to be a lower airway sound. And these are going to be fine crackles here. Also called rawls, or rails, some people say. Why does it sound like popping? Because basically the fluid is being uh, in the alveoli, and it's going to close the alveoli and collapse it a little bit. And when you breathe in or try and breathe out, some pressure is actually formed. That's going to pop open those alveoli. So that's why you hear that sound. So in both phases, you can hear this typically. And you can hear pneumonia, CHF. So I'm going to pause here at telectasis. That's when there's like partial lung collapse. So little parts of the lung will collapse, and when you breathe in, they pop open, like I said, which is why you're going to hear this sound. And because it's lower airway, you're going to hear it in the basins, not in the apex. So next is going to be rhonchi. You heard this in the bronchi. So it kind of sounds to me like if you had milk and a straw and was blowing bubbles through it. Especially when it's kind of thick bronchi, it's going to be secretions in the lungs usually. So think of things like pneumonia. All these are lower airway sounds, like I said, thick secretions. Yeah, we're right there, right in the bronchi area. Are you hearing it all the way through inspiration and expirations? So I played for you Strida before, but it just bears repeating. This is going to be basically the only sound on the list here that's going to be upper airway for you. Usually louder on inspiration. So these disease processes, cryptoglottitis, we're going to learn in the pediatric section here. But one of the things you got to watch out for, even in adults, is foreign body aspiration, which basically means there's something caught in their trachea. Okay, and then a bad allergic reaction we call anaphylaxis. See how upper it is? Don't press hard on the throat. So this person has both inspiratory and expiratory stridor. But mostly it's going to be inspiratory. So I would encourage you to actually listen to those yourself a lot so that you can actually know what you're listening to. You have to know all these sounds and what they actually mean. So the first thing you need to do is actually know what the sound is. You need to know if it's inspiratory or expiratory or both. You need to know where it is, upper or lower airway. And then all these lower airway sounds, you need to know how low it is. Is it all the way in the base? Is it the bronchial level? So all the way to the base would be something like crackles. Bronchi would be higher up in the lungs, wheezing, sort of midline there. So in your cardiovascular exam, you're going to have to expose the chest again. That way you can actually see, do they have a surgical scar, something like that? Like they've had, open heart surgery before. All right. Then we're going to consider all the things that have to do with the circulatory system. As we said before, the pulmonary and circulatory system work together hand in hand. So you have to consider their pulse, their blood pressure, and their respirations. So as far as their pulse goes, make sure you know what the rate is, how fast, how slow, is it normal, is it tachycardic, is it bradycardic? Their rhythm, is it regular? Does it feel like they're skipping a beat and it's irregular? You're only going to know that by actually putting your hands on patients and palpating a pulse on everyone you come in contact with. All right, it's just good policy no matter how long you're in this field. And then you need to know the actual quality. So things like you can relate it to the air movement, right? Where we did shallow, normal, and deep. Okay. But in the actual cardiovascular system, you're going to want to know, is it a normal feeling or is it bounding, which means that it feels like it's really coming out of the gate strong because the systolic is so high, and then it falls off rapidly off a cliff. That would be bounding pulse, or a weak pulse, or what we would call a thready pulse, which would feel like if you put your finger down on someone's pulse and it almost feels like someone's just running a thread underneath your finger, hence thready. It means that the systolic and diastolic are actually close together. So on these distal pulses, you want to compare left or right. If you're going to take a left radial, then at some point take a right radial too. Okay. Consider the skin whenever you're doing this, because when your blood actually can shunt, so instead of actually having a lot of blood around your extremities, it will shunt into your core. Think about people that have like hypothermia. The blood is going to actually go from their extremities, which are all that important, into their core, like their heart and their brain, because that's what needs to stay alive for you to actually be living, which is why people get frostbite and things like that. And then you can consider auscultating for abnormal heart sounds. Now, if you think the abnormal breath sounds and all those are hard to actually learn, there's several just with the heart. So S1 and S2 is normal sounds. I'll tell you, you don't have to know these. S3 and S4 are going to be some abnormal sounds sometimes. And then there's going to be things like friction rubs. There's going to be mitral valve problems, aortic valve problems that you would have to listen for. So just like the breath sounds, which you're going to have, or I'm sorry, the respiratory rates between adults and pediatrics, which you're going to have to know. You're going to have to know the difference in pulse rates for adults and children. So children are going to have higher respiratory rates, and they're also going to have higher pulse rates. So infants, when they're first born, they can have pulse rates up to 200, right? And 85 is normal for them too. So they can have an infant that's has a heart rate of 160, completely normal for an infant. Okay, but if it's an adult, then that's a serious problem. The same with preschoolers, 60 to 140, so 2 to 10 years old. By the time they're 10 years old, they usually don't go up to 140, they might go up to 110, something like that. And then infants, toddlers, 3 months to 2 years, they're regularly above 100. All right, the younger the patient, the faster the pulse, and you should know the normal adult pulse rate. So, like we were talking about before, stronger than normal pulse is going to be bounding. So, like I said, the systolic is really high. The diastolic is pretty high too, but there's a large spread between those two numbers. So you're going to feel a big bounding pulse out of the gate and then a rapid fall off on the diastolic, even if the diastolic is high. Just because the systolic is so high, we call that bounding. And you can have a pulse that's weak and difficult to feel, and that's just going to be weak. Like I said, thready is if you put your finger over someone's pulse and it feels like they're actually pulling a thread under your finger. So that's going to be a really close systolic and diastolic blood pressure. So weak is just going to feel normal, but real weak, weaker than normal. All right, and you're going to have to know all these pulse qualities by just actually taking pulses of people that have high blood pressure or low blood pressure, and you might not feel a radial. You might only be able to feel a brachial or a carotid if they're unconscious. So what you want to feel on the rhythm on the pulse, is it regular or irregular? Right? So you're going to know regular is going to feel like it's between 60 to 100. right? And all the beats are going to be in line. You can basically set your watch like a metronome. It's 60 beats a minute, 70 beats a minute. That sort of stuff is very regular. And it should be regular if it's a normal sort of pulse. Now, if it's irregular, that could be normal for the patient, so you'd have to ask that. But for most patients, irregular is going to be bad. It's going to feel like they missed a beat somewhere. So, like a beat just dropped. And as we said before, the blood pressure is going to be that hydrostatic pressure of the blood basically pushing against the walls of the arteries. Okay. So what you're going to have to notice if people start like having a drop in blood pressure, some hypoperfusion, some hypotension, several things may have happened, like more than one or usually just one. It kind of depends. So they could have lost blood. It could be a trauma stabbing, a shooting, a car wreck, that sort of stuff. They have internal bleeding. They could have external bleeding. They can have a loss of that tone. Like I said, in the arteries, you have smooth muscles with constrict to keep your blood pressures. But your blood pressure, like in the arteries, they're always constricting a little bit. But if they stop, the blood pressure is going to drop. And it's easy to kind of understand if you think about it. If you take a garden hose and then rapidly expand it, but keep the same amount of water running through it, the pressure is going to fall. And it's the same way in your circulatory system. All right, so you have to have sufficient vascular tone, which means that it's going to be constricted a little bit all the time, and then arterial constriction. All right, and the other thing that can drop your blood pressure is that your heart isn't pumping well enough. Okay, so it's not pumping strong enough, and so it's going to be hard to actually get a blood pressure that's normal on those kind of patients. So you should know, we'll get more into this as we go into the trauma section, which I believe is week 5, or maybe it's 6 to 8. So the blood pressure, when it starts to drop after a trauma, say in a car wreck where they have internal bleeding or a stabbing, gunshot wound, what have you, when it starts to drop, what's basically happening is your body can't compensate anymore. So it can't constrict anymore. It's getting too tired. It doesn't have enough energy to do that. It can't constrict the arteries enough to actually maintain a blood pressure. It can't pump fast enough to actually maintain a blood pressure. And so when their blood pressure starts to tank after they've had these traumas or had certain medical conditions, that's going to be a late sign of shock. So shock is going to be hypoperfusion. So low blood to the tissue. So the tissues aren't getting the blood that it needs. A bunch of waste products build up. As you saw in one of your case studies, lactic acid can actually like build up, so you get more acidic because you're having anaerobic metabolism, which is metabolism without oxygen because you're not getting the blood. And that's going to be late sign. So those people are really going downhill fast. Now, if someone has an abnormally high blood pressure, you have to watch for things like strokes because the arteries in your brain can burst and then you can have a hemorrhagic stroke, which means that it's just bleeding into your brain, the same as it would, you get hit in the head with a baseball bat because of all that force. Well, all that force from the high blood pressure ruptures some arteries, and you're going to have a really bad stroke. So we went over the BP cuff and lab here, so you're going to know all these. It's going to be the outer cuff. There's going to be an inflatable bladder, which you're pumping up with that aneroid there, and then that ball pump, one-way valve, pressure gauge, etc. And we showed you how to do that. And now auscultation is like listening with the stethoscope is what they mean, is the most common means of blood pressure. And we showed you how to get a blood pressure over top, I think in all your groups here, which basically just means that you're going to feel for a radial pulse. You're going to get it. You're going to pump up the blood pressure cuff until that radial pulse disappears. Slowly let it down until you feel a beat on that radial pulse again. And then that's going to be your systolic. So it could be something like 90, and then you're going to go slash over P, which means 90 over pout, because you can't get a diastolic doing that. So normal blood pressure. So hypotension is low blood pressure. That should make sense to you now. Hypertension is high blood pressure. So just like everything else that you're going to have to learn, you're going to have to learn here the respiratory rates of children and infants, the pulses of children and infants, and then the normal like blood pressures for these guys here. So it's obviously going to be lower on children. Now on children, the respiratory rate and the pulse rate are higher, but the blood pressures are low. They don't have as much, body mass to go through to actually pump, so they don't have as many blood vessels. They don't have as many capillaries. It doesn't have to be quite so high. So when a neonate is born, the first couple of days here, It depends on how much they weigh and how old they are, but typically 67 to 84, yeah, that's normal. So an infant 1 month to 12 months, we'll usually count all those people as a year old. So the lowest you're going to want to go is basically 72, then 104, and then you can read the other chart going up here. As they become, teenagers, it becomes more normal. They can have it slightly higher as teenagers, but typically not. All right, the neuro exam. The neuro exam is the longest examination that you can actually perform technically if you do all the parts. You're going to perform a neuro exam, one that we'll teach you here, on anybody that has a possible neurological problem, no matter what the cause is. Like they may have low blood pressure, but we still have to perform a neuro exam to actually get a mental status on these people more than just the APU that we showed you, the alert, verbal, pain, unresponsive. All right, but anybody that has a change in mental status. Now, uh, this may or may not include somebody that has dementia, that someone has told you they had dementia, a bystander, a nurse at the nursing home, etc. Anybody that might have a head injury, including people that have fallen, or anybody that is stuporous. There's several levels to this sort of medical terminology. Stupor means sleepy and difficult to wake up. You can think of somebody that like has a heroin overdose. They're going to be sleepy and hard to wake up if you can wake them up at all. But if you can wake them up a little bit by actually, shaking them quite a bit, and they can open their eyes a little bit, that's stupid. All right, anybody that's dizzy or drowsy, including people that have, alcohol intoxication. And then anybody that faints, something that we'll call syncope, and you'll have to know that term as well. Syncope means fainting or passing out. So you need to evaluate not just their level of consciousness. Okay, you're going to have to evaluate their orientation, which we'll talk about here in a second. But the ABPU is the thing we use in the primary assessment when we first get a level of consciousness. They're either going to be alert, which means they're looking at you whenever you show up, or they'll have their eyes closed and you can call their name or say hello. Anything that actually gets their attention, if they open their eyes, then they're alert to verbal. Or if you have to do a pain response or you squeeze their trap, that's pain. And then unresponsive if they don't respond to any of that. Now we'll go over this GCS, the Glasgow Coma Scale, more in trauma. You're going to have to know that. It ranges from 3 to 15, 15 being normal. All right. That's going to be the thing that most hospitals are going to want to know on the fly. First, the GCS, and then they're going to want to know their ANO status, their alert and orientation, which means if they're alert, they're looking at you, and can they answer all the questions, person, place, time, and event in that order, like I told you before. All right, you should know what a pupil is. It's the black center portion of the eye. It's the place where light comes in. Okay, it should be round. All right, and they should be of equal size. So, if the slide says they should be round, know that in some trauma cases, it's not going to be round. So if someone has an eye globe injury, it could look like a teardrop shape, for instance, and that wouldn't be normal, and you have to report that. But if there's no light around, uh, the pupils are going to be fully relaxed and dilated, which means they get bigger. Dilated means bigger. Okay, and you probably know that just from actually your normal life. And then if it's bright outside, your eyes are going to get smaller. The pupils are going to get smaller. So here are some of those. So the first person on top here, the blue-eyed person, they're going to have constricted pupils, and you can see how they're smaller than normal. So this is something you're going to want to watch for when you shine your light in people's eyes. All right. So are they that small to start off with? But notice, is it right outside where they were? And then you get them in the ambulance where the lighting is more normal. They return to normal then, and then you shine a light and they have a normal response. And then the second person is going to have, a dilated eyes. So they look bigger. So is it dark there where you're shining? So if it's dark and you shine your light in there and their pupils constrict at a normal rate, that's going to be normal, but those are dilated pupils. And then at the bottom is, this person has anisocoria, which means that their pupils are uneven, right? Because their right eye here is dilated while their left eye is normal. And you can have somebody that has it dilated on one side and then constricted on the other as well. So one of the things you're going to want to watch for when you shine your light on people, do they have a normal response, which means it actually constricts at a normal rate? And you can practice that on yourself or other people to see, or is it sluggish? That sort of thing you're going to want to know. So here's that term here from the bottom, anisocoria. So unequal pupils, that's what that means. Okay. So some causes of that. Okay. It's usually going to be a brain injury because of the way your actual nerves that control your pupils work. They actually go through the brain and then it splits. Okay. And because one side could be injured and not the other, one side can be dilated, one constrict. Right. So it's going to be things like actual brain injury. Maybe their head hit the windshield. Okay. They could be having a stroke, even brain tumors on one side of the brain or the other. If they don't have adequate oxygenation, okay, they're not able to breathe. They don't have adequate perfusion. And then some drugs or toxins. So you can think of drugs that constrict, like constrict both sides, right? And it's going to be anything that slows you down. So it's going to be your narcotic pills, morphine derivatives, heroin, that sort of stuff. Anything that excites your nervous system, like if it's fight or flight kind of stimulation, your eyes are going to become dilated, right? So if you have something like cocaine, methamphetamine, their eyes are going to be dilated. The reason is because it works up the fight or flight system. So if you're, being chased by a lion in the jungle, right? You're going to want to be able to see everything you can, which is why things like epinephrine will make your eyes actually dilate. And what we want to look for in the pupil is called pearl. So pupils equal rounded reactive light. Okay, so you want to make sure that when you shine your light on someone, their pupils are going to be equal, so they look basically the same shape and size. Okay, they want to be round, not a different shape other than round, and they want to be regular in size. And then when you shine your light on them, does it react normally? So another acronym you will have to know. Now, another part of this neuro exam, make sure that their muscle strength on one side and the other is normal or at least equal. Okay, so that could be as simple as putting your fingers in someone's hand, having them squeeze. Does it feel like they're squeezing at the same rate on one side or the other, or on both sides it's equal, or one side's stronger than the other? Think of things like strokes. That's why it's important. And make sure you complete a thorough sensory assessment. Okay, so if someone is in a car wreck, you want to make sure you can rub on the side of their leg, and even if their eyes are closed, they can tell you which side you're touching. Okay, that's going to be light touch. You can test for pain. That's a little cruel. Like if you think like you're causing pain, but what you're actually doing is just putting something sort of sharp on their leg. It doesn't have to be like a knife, nothing like that. That's not what I'm talking about. But it could be like the edge of a pin, something like that, like a PEN pin. Make sure they can feel and that they actually know their position. So, drugs that alter your neurological function, think alcohol, right? What are the cops going to do when they get you to come out? So they're going to have you walk that line toe to toe, stretch out your arms, close your eyes, touch your nose with your left, and touch it with the right. That's to make sure that you actually know where your body is in space. So you know how to actually find your nose, even if your eyes are closed. That's something called proprioception, which has to do with your neurological function. Okay, you have to do that sometimes in some people, uh, such as people that have cerebellar stroke, because it affects movement. All right, and then you want to compare both distal and proximal sensory and motor responses from one side to the other. An anatomical region. So we're going head to toe here. You want to palpate the skull all the way around, right? You got a big skull there. So from their forehead all the way to the back of their skull. All right, you're going to check the patient's eyes, make sure it's pearl, like we talked about before. Make sure that they don't have any sort of jaundice in the sclera, or there's not bleeding into the sclera. All right, you want to feel the patient's cheekbones. Did they like fracture their face? And now you can actually feel the bones moving under your hands. Okay, the same thing with their jaw, their maxilla, and their mandible. Okay, and then it's real important to check for fluid or blood coming from their ears or nose, because that can mean that the covering that lines the brain actually tears and now blood is leaking out through those open orifices there. So, like I said, the upper and lower jaw, so the maxilla and the mandible. All right, so open the patient's mouth, look for like broken, missing teeth, things like, if they hit the steering wheel with their mouth. All right, any unusual odors. This could be things like you can actually smell when someone has high blood sugar sometimes, and we'll go over that in the medical section. It's kind of a fruity smell. It's been described as the smell of juicy fruit. If you know what that gum is. Now, some people have the gene to actually smell this, and some don't. I don't. So I had to rely on my partners to actually tell me this. Uh, my sense of smell and this kind of stuff, because that smell from high blood sugar is actually similar to the smell from alcohol. It's hard for me to tell someone is that drunk unless they're very drunk and breathing right on me. But notice any unusual odors in their mouth. And we talked about the chest before. You can palpate that. So if you're palpating the chest, one part you're basically not going to palpate is the back occipital region of the chest. All right, but make sure they rise and fall equally, both sides. Like I said, cervical scars, abnormal breathing signs, retractions, that sort of stuff. All right, for the abdomen, you're going to palpate all four quadrants. Because remember, we talked about in the anatomy section, we divide the abdomen in four, with basically the middle line going through their belly button. All right, so you're going to check for tenderness, which they're going to tell you about. If it's rigid, which means their muscles are very tense even before you touch it, and you're going to check for guarding. So guarding is actually tensing those muscles when you palpate it. So it may feel soft when you first start to touch them, but then they're going to immediately try and guard that area from further injury, and that's why we call it guarding. So we're going to check the left upper, left lower quadrants, right upper, left lower quadrants, and you need to know the organs that underlie those areas. We're going to inspect the pelvis. So we're going to look at, is it symmetrical? All right. Obvious bleeding, which would be things like swelling. It's really red under there, that sort of stuff. Any deformities? And then you can actually feel, like, we'll show you how to palpate the pelvis here on Wednesday, I think. And you're going to check for the extremities. Like all this stuff, you're going to check for that decapitulus stuff, which you're going to have to know the acronym for, like I said. For symmetry, cuts, lacerations, bruises, which means contusions, swelling, which is edema, obvious injuries, bleeding. Okay, palpate all this stuff. And make sure on the extremities, like we said, that one pulse is the same in one arm to the left, the same from one leg to the left. And the same for the posterior, which is the back. All right, you're going to check for all that decapitulus. Is it symmetrical? All right. We're going to show you how to feel the spine from basically the cervical spine all the way down to the sacrum or the coccyx. And then we're going to check to make sure there's not anything we would call step-offs or this is what's going to be a step-off. So you don't have to know what spondylosis is, but just notice here on the right. So obviously these spines should be in line, right? But if you have a break here on one of them is going to like jut out into the back and it's going to make a little step, right? And you can actually feel that whenever you palpate someone's back, especially if they have a broken back injury from back car wrecks, things like rollovers, which would be the worst car wrecks. Hey, we showed you pulse ox here in the lab. Just know pulse ox measures the percentage of oxygen attached to the hemoglobin. That's basically the definition. Yeah, and it's at the capillary bed that it actually measures that. Now, here on the bottom, patients with difficulty breathing should receive oxygen regardless of their pulse oximetry value. Yeah, but still try and keep it between 94 and 99%. So, capnography, this is the waveform that shows you, basically how the patient is exhaling because it measures carbon dioxide. And like I told you in class, there are videos on Moodle about capnography or EMT so you can actually understand. And you're going to have to know this basically not for the National Registry, but for your job. Anyone's going to expect you to know this when you're actually cleared to actually practice, like on an ambulance. So you'll go to work somewhere. And even if they never taught you in class, they're going to try and teach you this in real life because you have to know this even though it's beyond the national standards. And then you know about the blood glucose monitoring. Yeah, just remember that whenever you hit that monitor button, it's the NIBP, non-invasive blood pressure. All right, reassessment. If the patient is stable, it's every 15 minutes technically. What's really going to happen is most of your monitors are going to be programmed for every 10 minutes. But if they're unstable, you have to do it at least every 5 minutes. Right. So I wrote in here on the slide every 3 to 5 minutes. So I would prefer 3 in real life. But if there's a test on a question on a test or on a quiz or something every 5 minutes for unstable patients, every 15 minutes for stable patients, that's going to be the minimum. Okay. Now you can go more per minute. So you can do every 5 minutes on a stable patient in real life, or you can do every 2 minutes on an unstable patient. But it needs to be at least every 5 minutes for unstable, at least every 15 for stable patients. And what you're doing on this reassessment, you're then going to repeat the primary assessment, which think it's going to be your ABCs, it's going to be your airway, breathing, circulation. You have to repeat that and constantly repeat it. You're going to want to reassess those vital signs. You take the vital signs in the secondary assessment, okay? And you're going to compare those baseline vital signs, which is basically, what it is normally or what your first set of vital signs were that you obtained. You can obtain some vital signs during the primary assessment on the sheets that we're going to give you. The vital signs occur in the secondary assessment, so remember that. Even though you can do it on the primary, technically they occur in the secondary assessment. And then you look for trends. Is their blood pressure getting, is it staying the same? Are they dropping in blood pressure? Do they have hypotension now? Did their pulse decrease or increase? And same with the respiratory rate. Then you're going to reassess their chief complaint. Did they improve? Do they still have the same amount of abdominal pain as when you first showed up? Is it better? Is it worse? Okay. And then what's the nature of the new problem? Well, it got worse and now it's actually not just in my abdomen, it's in my back now too. That sort of thing. So don't ask them specifically, but say if there been any changes and then they could tell you. You don't want to put ideas in their head, basically. You're going to recheck what you've actually done. So you gave the patient oxygen because they're having difficulty breathing. Did their SpO2 raise? All right. So the most important part of the rechecking the intervention is to make sure that the ABCs have been corrected if they were wrong, and if not, make sure they didn't get worse. All right. So you're going to trend. So that's why you need to have at least 2 vital signs before you get to the hospital, so you can actually establish some sort of trend. Make sure you manage any bleeding, and then if you manage the bleeding, check it again. Are they still bleeding, or did they start bleeding after you've done something again? That sort of thing. And always consider the need for new interventions. All right, always be thinking in this job. So as I said, identify, which is why you repeat that primary assessment, the ABCs, and then treat the changes in the patient condition, and then document any changes. Did they get better after oxygen? Did they get worse? All that needs to be documented. So, like we said before, for the unstable patients, approximately, at the very least every 5 minutes, but every 3 to 5 minutes. All right, for stable patients, every 15 minutes. Always reassess those vital signs, trend those vital signs. And we have finally come to the review section. So close to the end. All right, during the scene size up, you should routinely determine all the following except one. So there's only going to be one correct answer. I'm going to tell you the first 5 things that we're going to teach you that's on that assessment sheet, whether it's medical or trauma, is going to be make sure that you have your body substance isolation, PSI, your personal protective equipment, PPE. Make sure the scene's safe. All right. Get what the dispatch information on the MOI NOI is. Get the number of patients you have, not what type, but what number. Identify any additional resources that you need, and then make sure that you know that whether or not you're going to use a C-collar on this patient. So the only one that's different here from all those that I explained is going to be B. Okay, so you arrive at the scene of an injured person. Usually this is going to come out as call as an injured man down. As you exit the ambulance, you see a man lying on the front porch. Okay. He looks like he's shot in the head and a large pool of blood. You should what? So what's the first thing that you should actually know to do here? So you got to make sure the scene's safe because you don't know who shot him or where they are. All right. So that should tell you the answer on this one here. Yeah, only D. So get the ambulance, get away several blocks at least. Tell the dispatcher where you are, that you're staging, and then call for PD. Tell them what you found. All right, findings such as inadequate breathing or an altered level of consciousness should be identified in the. So this is going to be, you're going to need to know these different sections of the patient assessment, where it starts with seeing size up, primary assessment, secondary assessment, reassessment, and where everything is on this sheet. Right. So that's going to tell you where this is on the sheet. So inadequate breathing, altered level of consciousness, that's in the ABC section. So where's the ABC section? That's in the primary assessment. All right, which of the following would you not detect while determining your initial general impression of the patient? Okay, so think about it like this. The general impression is going to be inspection mostly. Like you walk in, it looks like it's, a 70-year-old male, right? He's sitting there tripoding. He doesn't have his shirt on. Looks like he has retractions. What thing are you not going to actually see, basically? And you're not going to see someone's heart rate, all right? You may see cyanosis, right? You may hear something. You may see bleeding that's severe, but you're not going to like see a heart rate. You're not going to hear a heart rate. All right, your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma, which means bruise, on her forehead. After protecting her spine, and we'll show you how to do that in class, and administering oxygen, what should you do? This is a question that kind of asks you, what's next on the sheet. So you've taken C-spine precautions for this patient, making sure that she doesn't further injure her cervical spine. Right, she has an altered level of consciousness and a large bruise on her forehead. So after all that, you've already got the level of consciousness. What should you do? All right. So you don't transport immediately, right? What's going to be the next in the series? It's going to be B, right? Life threat stuff. So you're going to perform a rapid exam, which you can do in the actual ABC assessment section. All right, a semi-conscious patient pushes your hand away when you pinch his earlobe. All right, you should describe his level of consciousness as black. So he didn't do anything until you actually pinched him. So, a pinch hurts, right? So what should it be? It should be. All right, assessment of an unconscious patient's breathing begins by what? All right, how do you start? Get to know whether or not the person's breathing is correct. All right, what are you going to do? So the answer is B. All right, you can't treat breathing. So until the airway is actually patent, so it's actually open. So it's the first thing you're going to want to do. So not everybody needs an oral airway. All right. The first thing you're going to do is a head tilt chin. I think your BBM skill, right? All right. So you may get confused by the respiratory rate and depth question, but you got to make sure that their airway is patent first before you actually check if they're breathing here per the sheet because they're unconscious. All right. Your 12-year-old patient can speak only 2 or 3 words without pausing and taking a breath. Okay. He has serious breathing problem known as what? So I described this in the lecture. Every medical professional knows this actual phrase, so you should know it too. It's B. It's 2 to 3 word dyspnea is what it's called. If it's more than that, you can tell them it speaks about 4 words before it has to take a breath, that sort of thing. But 2 to 3 word dyspnea is usually the worst. All right, how do you determine the pulse in an unresponsive 8-year-old? So 8-year-olds are pediatrics. Okay, so we haven't done peds yet, which makes this question kind of hard. I can't remember if it's actually in the book, but I'm going to tell you, you're going to have to know this eventually. All right. So if they're unresponsive, right, even though we haven't done peds yet, you palpate the carotid in unresponsive patients. So that's how you should reason through this. All right. So if they're conscious, you would actually use the brachial pulse. If they're unresponsive, though, everybody gets a carotid pulse. Check. So the brachial pulse is for kids younger than 1. All right. So it wouldn't be the radial pulse because that's for kids that are older than 1 and who are actually conscious. They're responsive, right? And you never palpate a pulse with your thumb. Your thumb has its own pulse, so you're going to get confused between the patients and your own pulse rates. So if they're unresponsive, it doesn't matter if they're pediatric or not. You're going to actually just palpate the carotid. All right. When assessing your patient's pain level, he says it started in his chest and spread to the legs. So here it says, this example, what part of OPQRST mnemonic? Okay. Like I said, you're going to have to know this mnemonic. You're going to use it all the time. Okay. So what part of it? What part is pain spreading? What would you think? And it's radiation, basically. Region also means where the pain is.